Excuse me, may you close the door there so people will come? Okay. So, I have the real pleasure to introduce Professor Rod Sandal. Rod Sandal is an emeritus professor in clinical psychology at Linköping University in Sweden. He is a psychoanalyst in private practice in Stockholm. His research concerns psychotherapy process and effects and socio-emotional training. Something more than 1 year ago, I organized a similar seminar for the association of all the modalities of psychotherapy in Italy. And so I asked many colleagues which kind of methodology we should explore in this seminar. And one of my colleagues, Paolo Migone, that is the editor of the most important journal in psychotherapy in Italy, told me, well, I would propose to explore the CHAP. And I said, what's the CHAP? I never heard about that. And he provided me some papers, and I found this tool so smart, so simple, so clever, that I found it was so interesting, so beauty to use it in our research program. The frame of reference you will see is a psychoanalytical one, but what I think, this is a real piece of research today, what I think is that this can fit very well our epistemology. And we have started to make some bridges between the frame, the psychoanalytical frame of this methodology and a Gestalt therapy frame of this methodology. So we are exploring the possibility to reframe this interview in Gestalt therapy terms. We have started this process, and we started this process with Floriana and with Margherita, and we will say something about this in the last part of Rod Sandal's presentation. So, I'm really glad you are here, Rolf. I really appreciate your availability to come, and I think we are all ready to learn and to explore with you this methodology. Thank you so much.
Thank you very much. That was a brilliant introduction. I don't dare to go on, really. Anyway, thank you very much for inviting me to this seminar, which I think is very ambitious. And I hope you have had a couple of stimulating days, and that you will have another few hours equally stimulating with me together with the chap. I have noticed that you have been focusing on assessment these days, according to the program. Assessment of change, more precisely. And I just wanted to have you notice that assessment of change is but one of the essential components in doing outcome research in psychotherapy. The other part is equally important, and that is the design, how you design a study. Because you have to design your study in ways that you can eliminate a number of systematic errors, so-called confounding factors. For instance, the influence of time, the influence of selection. Patients select themselves to therapy, and that is not on a random basis, etc., etc. So design of the study is equally important as assessment is. Now, The program during these hours is as follows. I would talk about 30, 40 minutes about the theory and the thinking behind the chap. And as I've noticed, you have not had a long break before today, right? Yeah. I suggested to Johnny we should then take a break for about 15, 20 minutes for you to have coffee and go to the toilet. I think 5 minutes as you had is too little. So at least for my part, I would have preferred to have a longer break. So we will have a break, and then I will introduce to you a case for us to generate or produce material for us to discuss in terms of the CHAP model. So I will do an interview with a psychotherapeutic patient who has terminated psychotherapy a while ago, and I will do this interview according to the CHAP model. And then I will introduce the second part of the CHAP routine. The first part is the interview. The second part is the rating part, where you sort of rate or scale how thorough, how radical, and how much change has come about as an effect of this psychotherapy. So, excuse me, I have a cough. It's a little bit irritating to you too, I realize that, but it's more irritating to me. We want to help people change, don't we? So, in order to be able to feed back to us how we have succeeded, we have to make some kind of assessment of change. How do we go on measuring, as it were, change? There is a dogma in psychotherapy research. It's called the gold standard. The gold standard refers to how scientific people in the psychotherapy realm feel or think that outcome research should be done. And according to this dogma, among other things, there is the idea that change is a difference. It's a difference between a pre-measurement, pre-treatment measurement, and a post-treatment measurement. And that is, it's called the D as the difference, as in difference, and it may be standardized and be transformed in different guises, but essentially it's a difference between a pre-measurement and a post-measurement. Now, I think that is an okay way to measure change or talk of change in certain contexts. For instance, in economy, a difference is a very sensible and reasonable and meaningful way to assess change. For instance, I want to have my salary raised with a certain amount of money, for instance. Or in medicine, I would like to have my blood pressure, especially at this particular time, lowered from 180 to at least 140 or something like that. So meaningful change in economy, medicine, and some other context is a difference. It's easy to do that. It's easy to apply an instrument, a state before and a state after the treatment. But there are some problems. There are a number of very serious problems that have been discussed for ages, at least since the 1970s or something like that. A number of psychometricians and statisticians have been noticing that there are problems with this way of measuring change. And now you have to excuse me. for, excuse me, for being a little bit technical. I call this way of regarding change, of viewing change as a difference, the incremental view, because it has to do with a difference between how it was before. I had a little salary, and now I have more salary, and I have a very high salary, for instance. Or I used to have a high blood pressure, I have less blood pressure and lower blood pressure. That's the incremental view of change. The problems are with this thinking in terms of moreness, being more or less, if you want to, are the following. And here I will have to be a little bit technical. To begin with, measuring change as a difference on some kind of scale, self-report scale or an observational scale or whatever, presupposes or requires that the change scores are measured on what is called an interval scale. Are you familiar with that concept? Familiar scale? Those who have studied psychology are probably, at least. You know, what we would like to have here is, can you see this? A little, it's a little bit vague. This is an interval scale, where we have here a measure of an interval of true change. This is a true change in some kind of psychological function. And what we would like to have is that true change, equal amounts of true change here and here, would have equal amounts of score intervals. You follow me? Good. Now, many, or probably most scales in clinical psychology are not interval scales. They are scales like this, for instance, where you have true change here. This amount of change is equal, or should be, roughly equal to this amount of true change. But you see, since this scale has a ceiling effect, you see, you cannot have equal score differences in this particular case as in this particular case. So you will underestimate the change in the upward part of the scale. Do you follow me? Yes. Good, very good. That's the first and very basic requirement, which is very seldom thought of or discussed. Now, another problem with different scores is that it has to do with their reliability. You're familiar with what reliability is, I guess. It's the opposite of chance errors. Chance errors, random errors, are always present, but we want them to be as small as possible. Now, the reliability of change scores, which is called sometimes gains, but that's the difference, the difference scores, is that the reliability is lower than the reliability of either the pre-measurement or the post-measurement. And sometimes it's substantially lower. So if you have a reliability of about, say, 0.85, which is ordinary, not too bad, not very, very good, you will have a reliability in the difference score of about 60, which is not good enough. So that's another problem. So we would like to then cope with another problem, because this low correlation, the reliability, will be lower the higher the correlation between the pre-test and the post-test. And that is important, you see, because we would have to decrease the correlation between that pre-test and the post-test. But as we decrease the correlation between the pre-test, I'm awfully sorry that this is very technical, but anyway, as we decrease the correlation between the pre-test and the post-test, we have to ask ourselves, do the pre-test and the post-test measure the same thing? That's essential. I mean, otherwise it would be like comparing apples and oranges or whatever it is, you know? You follow me here? Good. Then there is another problem still, and that is that when you compute the difference in raw scores, in observed scores, between a pre-measurement and a post-measurement, you will produce also a negative correlation between the change, the gains, the change score, and the pre-measurement scores. And you won't have that, because that would have as a consequence, for instance, that people who are low scorers to begin with will have greater change, whatever their true change has been, than people who started up at a higher level. Can you see me? You can see me, I hope. But can you understand me? Do you? Good. So we won't have correlation, any kind of correlations between a pre-test and the change score, you see. But the pre-post differences always correlate with the change scores. And finally, I think it's final anyway, but there may be some more problems, but I don't know. It's a phenomenon which is called regression to the mean. It always occurs, it's unavoidable when you do a repeated measurement, like in a pre-test or pre-treatment test and a post-treatment test. What happens is this, that people who are scoring low before the treatment, they will increase their scores, whereas people who are scoring high before the treatment will decrease their scores. And you will draw the erroneous conclusions of that effect, that it has anything to do with treatment, which it hasn't. It's a statistical fact of randomness, you see. And there are ways to avoid it. You have to do two pre-tests, pre-treatment tests, in order to eliminate the regression to the mean, but I won't be technical. But it's avoidable, but it's ordinarily not, you see. So these are the problems with the incremental model, the incremental view of change. So I was thinking how we should try to assess change some other more meaningful way. And I was starting to think in a way phenomenological. How do we know, how do we feel that a person has changed? Or that we ourselves have changed? Well, we have some perception of surprise, for instance. We feel surprised. We do not recognize ourselves. We become impressed, for instance. Oh, that was a kind of very impressive change. That's the feeling we have. That's a perception we have. Or if there has been no change, we feel disappointed. We feel frustrated. We may feel irritated or angry even that nothing has changed. All these are phenomenological states of mind that all signify the presence or the absence of change. So I would like to introduce what I call the transformational view of change, or if you want to, the configurational point of view. the transformation, as opposed to the incremental view of change. The transformational is a qualitative way of trying to assess change. Look at this. This is a pattern. Imagine that this is a pattern of inner structures, for instance, in a person. This may be the superego, for instance, if you excuse me. I'm kidding now. I'm a psychoanalyst light. I'm not a psychoanalyst orthodox. But anyway, let's think of these as structures of the mind. Okay? And then people are, for a number of months or years, I don't know, in a Gestalt therapy, and then you find out that this is what has happened. This is a qualitative change. The area is exactly the same here as it is here, but it's quite another organization. I'm not sure whether it's better or worse, but it's different. Isn't it? Yeah, no doubt about that. This is a difference in a qualitative sense of the way. So, in this view and this perspective, we are talking about differentness, not moreness. We are talking about differentness. So, how do we go about trying to measure? And measurement is a way of assigning, numbers to an experience or to something, as in the physics, but in the psychological realm, we are trying to assess change by, or measure change by assigning numbers to change. Change, to begin with, is qualitative. As a pattern or a configuration or a structure changes in the way I try to show you. For instance, think of changing the furnishing in your apartment. Not buying more chairs, but just moving them around. That is qualitative change. If you add a number of chairs, that's moreness. But if you just change the layout of the furniture as they are, that's differentness. And when you do that, you will realize that the change of a pattern may be more or less thorough or more or less radical. You may move like this, or just move a couple of chairs like this. The first is much more radical. It's much more thorough than the other way, than the second way, where you just move these chairs and switch or swap their position, for instance. And this radicalness may be quantified. It may be measured if one wishes to do so. I mean, you could assign numbers to how radical a change was this as we observe it. Do you follow me as far as this? Good. Still, I would say that one of the great ideas about the chap is that you don't have to do this. You don't have to quantify things. You just can listen to your patients or to listen to the interviews which an interview has made with the patient and do some kind of qualitative study of it. It's often more informative. I would say it's always more informative to be qualitative than to be quantitative. But other people outside your association and outside my association, they are asking for numbers. How much better? How many people will improve, etc.? And how much do they improve? And what does it cost, of course? But for you as clinicians, and also as researchers, I would say that often the qualitative information is much more valuable because patients have a lot to say to an interviewer after psychotherapy, which they did never communicate it to the therapist, in my experience, really. And I have now made a great number of interviews with patients where, when I asked them that, well, did you tell this to your therapist? Oh, no, I wouldn't dare to do that. So merely doing a qualitative post-treatment interview is very, very, very informative. But anyway, as people are asking us for numbers, how do we measure the transformation? Well, let's ask ourselves how radical, how extensive, how thorough is the change that we witness in a patient. According to the patient's view, mind you. The phenomenological perspective is that how astonished are we? How impressed are we? How proud may we be as therapists, of course, if we are doing the interviews ourselves, for our achievements? Or how disappointed, how impatient, how frustrated are we? This is a matter of feeling different, of feeling a difference. And I call this the experience of the state of having changed. Patients have these experiences after completing a therapy. Most of them actually do have this. Some people have experiences of having not changed. And there is a too high a number of patients who have the experience of having changed to the worse, really. You would be amazed if you studied the research literature on that subject. But anyway, that is also change, of course, but to the worse. The experience of having changed is, I would say, measurable in terms of how radical, how thorough, how extensive we feel that this change has been on the basis of what the patient tells us. So we start to ask the patient, well, how do you feel and what are your experiences about the psychotherapy you have been in? Just tell me about what benefits you have had, what losses, possible losses you have had as a result of your psychotherapy. How do you think your expectations were fulfilled or not fulfilled? Was anything happening that you did not expect during your therapy, which you think was good, or which you think was not so good, etc., etc. And then you will try to have the patient talk, just like they do, I guess, in your kind of therapy too, as freely as possible. And you have a recorder, and you record the interview, and you transcribe it afterwards. That's it. It's nothing actually very original. I mean, lots of people have been devising follow-up formats of interviews. And this is not very specific, but that is the chap anyway. And it's a way of thinking about follow-up, which I think is a little bit different. And I think it, in contrast to the incremental view, which I think is a manifestation of American pragmatism in philosophical terms. I mean, they emphasize the usefulness, the purpose, and the efficiency, etc., and the success of any kind of activity. I think the chap manifests what I would believe is continental phenomenology. I mean, structures of consciousness as they are experienced from the first person point of view, which is the patient. So let's start with doing a follow-up interview. Outcome in psychotherapy is a process. It's not a finite thing that you can pinpoint at a particular point of time. It changes all the time, you see. Sometimes to the worse, and sometimes to the better. But it's a process. So that's why you should, or one has to do, repeated follow-up interviews, whether you are doing it the CHAP way or any other way, incrementally or transformationally. And what we have been doing is that we have been doing interviews with patients 3 months after treatment, the termination of treatment, after 6 months, after 12 months, after 24 months, etc. I think the longest was 24 months. Long follow-up, for long-term follow-up after psychotherapy is extremely unusual. The standard is to follow up patients for a year or so. I've directed a study where we followed up patients for 3 years, which is extraordinary. There are few studies internationally that have followed up patients as long as that. But it's essential to do that, because otherwise you won't be able to follow the post-treatment process. Also, you may use the CHAP format to study what happens during therapy. The other day, last week actually, I had a manuscript from a Portuguese colleague. His name is Antonio. I'm sorry, bad name. Bad recall of name. Anyway, he's a psychoanalyst in Lisbon. And he has recorded a whole entire psychoanalysis, 3 years. And every session, he noted on the basis of his recordings what kind of change incidents happened. And then he categorized them in 4 or actually 5 parts in terms of the change variables of the CHAP. And that's very interesting, you see, because to begin with, what happens is that symptoms are decreasing. They're talking much more, patient is talking much more about the symptoms, and then gradually he's coming to the more basic conflicts, intrapsychic conflicts that he has, and that happens in the 3rd year, actually. But any clinician can do this, you see. Just systematically record what happens in terms of CHAP change variables during your therapy. And we will discuss afterwards to begin with Floriana, how this may be adapted to the Gestalt type of psychotherapy. The interview follows a very informal format, unstructured. There is an interview guide in the manual. I think you have had parts of the manual relayed over the internet from Marja. No? Yeah, okay. We usually have, and I think it's preferable to have an independent interviewer, a person who is not the therapist, because the therapist has too much interest and too much feelings about the process to be able to sort of take the necessary scientific distance. So we have an independent interviewer who is doing the interview. The interview is recorded and transcribed, and then there are a number of 1 or 2, preferably 2, other persons who listen to the interview or read the transcription and make the ratings. And then these ratings are put into a computer, and then you push a button, and then you have the findings, you know. It's very easy. So, these are the background for the CHAP format, the CHAP routine. And it's 11 o'clock. I think you're a little bit tired now. So why don't you take a break for 15 or 20 minutes? What? 20 minutes? Okay. There are too few toilets there. I noticed that. So let's take it 20. Okay. So we gather here again 20 past 11. Okay? Bye now. Thank you.